Assalamu alaikum everyone. The next topic of discussion is scarlet fever, is also known as second disease. Its incidence is common in childhood between the age of 5 to 15 years, although it can affect individual of any age. Generally occur in association with strep cases of tonsilopharyngitis. What are the causes? So pathogens group A beta hemolytic strep, known as strep pyogen, which produce erythrogenic exotoxin ABRC. Previous infection does not rule out additional episode of the disease as there are several different types of scarlet fever toxin. So it's caused by Streptococcus pyogenes and route of transmission is by air droplets. Clinical features, so incubation period is 2 to 5 days. Initial phase there will be acute tonsillitis. So the symptom will be fever, malaise, headache, chills and myalgias and tonsilopharyngitis. So there will be sore throat and difficulty swallowing, white coating on the tongue and enlarged cervical lymph nodes. GI symptoms like abdominal pain, nausea and vomiting, these are possible in young children. Then we have exanthem phase. So the rash appear 12 to 48 hours after the fever and there will be scarlet colored maculopapular exanthem which is bright red color rash. Presentation, so it's fine erythematous sandpaper-like texture and it blanches with pressure. Non-blanching petechiae are often additionally present and it can be pruritic. There will be Partia lines, which is a key sign of scarlet fever. These are a red line, which are linear, and these are due to the confluence of the petechiae. Mostly present in the groin, underarm, and elbow creases, like flexor area. Location should begin on the neck and then disseminate to the trunk and extremity, and duration is approximately 7 days. The characteristic scarlet rash is said to resemble goosebump, which is erection of the hairs, piloerection with a sunburn. So it resembles goosebumps that occur with the sunburn. This is the image of scarlet fever showing us a typical rash giving a sandpaper-like texture. This is another image of skin manifestation in scarlet fever. Then we have tonsilopharyngitis, so pharyngeal erythema possibly with tonsillar exudates, and there will be strawberry tongue. Bright red tongue color with papillary hyperplasia, which is revealed once the white coating has sloughed off. Typical red flushed appearance of the cheeks with perioral pallor. So there will be perioral pallor, cheeks will be flushed, and red appearance will be present. This is strawberry tongue showing hyperplasia of the papilla. This is white strawberry tongue. And this is the image showing perioral pallor and the cheeks are flushed and red. Then we have desquamation phase, so it appears 7 to 10 after resolution of the rash. Skin desquamation, so desquamation of the skin in flakes affect face, trunk, hands, fingers and toes. So it occurs about 7 to 10 days after resolution of the rash. And this is the image showing desquamation in scarlet fever. Finding like coryza, rhinorrhea, cough, hoarseness, anterior stomatitis, conjunctivitis, and ocellular lesion are atypical for scarlet and warrant further investigation. Diagnosis of the scarlet fever. So scarlet fever is primarily a clinical diagnosis. Pathogen detection. So throat culture is the gold standard, but it takes more time. Rapid antigen detection testing. So it's a rapid strep test. Blood and urine study, so CBC count show leukocytosis with left shift, so leukocyte will be elevated and possibly eosinophilia over the course of the disease. Urinalysis and LFTs may indicate complication of scarlet fever, and there will be elevated inflammatory marker like CRP and ESR. Other tests, so during the course of the disease, elevated ASO and anti-deoxyribonuclease ADB titer. So anti-ADB titer and ASO titer, they show retrospectively diagnosing a strep infection. Like previously, there was strep infection due to which these ASO titer and anti-ADB titer will be elevated. Positive tourniquet test, which is known as Rumpel lead capillary fragility test. DDs, so there are different DDs. Kawasaki disease is usually very similar to the scarlet fever, but it is treated with conjunctivitis and does not respond to antibiotics. Treatment. So, what are the indications? All cases of scarlet should be treated with antibiotics, both to prevent complication and to prevent transmission. Drug of choice is oral penicillin V. Alternative, a patient allergic to penicillin, so macrolides can be given. In case of recurrence due to antibiotic resistance, give cephalosporin. So, drug of choice is oral penicillin V. If the patient is allergic to penicillin, so give macrolide. And if there are cases of recurrence due to antibiotic resistance, so give cephalosporin. After 24-hour antibiotic treatment, the patient is no longer infectious and may return to daycare or school. The aim of antibiotic is to prevent complication and shorten the period of infectivity. What are the complications? So scarlet fever is considered one of the non-suppurative complication of the strep tonsilopharyngitis. Other complication of gas infection may also occur during or following scarlet fever, especially in patients who did not receive antibiotic treatment. So non-suppurative complications, we have post-tribulal nephritis, acute rheumatic fever, sudden hematuria, and we have pediatric autoimmune neuropsychiatric disorder associated with strep infection. And then we have suppurative complications. These are cervical lymphadenitis, retropharyngeal or peritonsillar abscess, otitis media, sinusitis, and mastitis. So that's all about scarlet fever. And this is the image that shows partial lines. These are red lines and these are formed due to the confluence of the petechiae.